there was a question on liver resection, and they had asked about the operative steps for anatomical liver resection. Okay, so this is a relatively easy question. So in anatomical liver resection, we know what are the basic operative steps. So what we do is, the answer here is A, but here we have to remember what is the conventional steps for a right hepatectomy. So say you are doing a anatomical right hepatectomy, then how do you do conventionally? So what is the first step is mobilization. Why is it important? I'll tell you later. So any anatomical liver resection, first thing that we have to mobilize the liver. Suppose you're doing a right hepatectomy, you start mobilizing the right lobe of the liver. Okay. Then we go to inflow control. So in inflow control, you take control of the, say you're doing a right hepatectomy, you take control of the right hepatic artery and the right portal vein. Okay. So once you have inflow control, then the other thing is outflow control. So you control the right hepatic vein as well. So once you mobilize this right lobe from the IVC, you take control of the right hepatic vein as well. All right. And then you start with parenchymal transection. Okay. So this is a conventional way of doing any hepatectomy, any anatomical hepatectomy. All right. So what is the catch here? Now there is something called as anterior approach. Okay, so this is your NEET SS like that. Yes, this is how we do a conventional hepatectomy, but you should also know about the anterior approach. So what is the difference between anterior approach and your conventional approach? So both are anatomical liver resection. The only difference in anatomical approach is that we don't do mobilization. So this step comes in the last. Okay, so in anterior approach, the mobilization of liver is the last step to done. Okay, so first what we do is anterior approach is inflow control, and then we start with liver transection. We also don't take the outflow, because unless until you mobilize the liver, you cannot take control of the right hepatic vein. So for venous control, you need to mobilize the liver. So in anterior approach, what we do is we straight away take inflow control, and then we start transecting the liver. Okay, then we start transecting the liver. So what is advantage of doing that? Why do we favor, why do we do anterior approach? So that is indicated in patients who have a very large SCC. Say you have a very large tumor like this, occupying whole of the right lobe. So if you try to mobilize this initially, what will happen is that there will be fracture of the tumor. There will be bleeding. Okay, because if you have a very large tumor, this lobe becomes very stiff. And if you try to lift it from the diaphragm, from the IVC, there is a high probability that this tumor may just break. Okay, or they may be bleeding, and it can be a non-oncological resection. Okay, so in these type of very bulky tumors, what we do is we just take control of, since the porta is free, we take control of the right hepatic artery, right portal vein, and once you do that, you'll get a line of demarcation, and straight away you start transecting. So you start from anterior to posterior like this. So we start, just cut it, and once you separate the right from the left lobe, you'll have access to the right hepatic vein. Then you tie off the right hepatic vein. And once we have done everything, inflow control, outflow control, parenchymal transection, then mobilization is the last thing that we do. So mobilization comes in the last. So this is what we have to remember, that in a conventional hepatectomy, you start with mobilization, but in patients who have a very large or bulky tumor, we start with inflow control followed by parenchymal transection. Okay, so this is how the order is. So if they ask you about anterior approach, what is the order of hepatectomy? That would be inflow control, then parenchymal transection, then outflow control, and then mobilization. Okay, so that should be the order of liver transection if they ask you about anterior approach, which they can ask in your NEET SS, not probably in NEET SS, but yes, in NEET SS you can definitely be asked about what is the order of liver transection or liver surgery in anterior approach, and what is the advantage of anterior approach. And this is where we use the hanging maneuver. Okay, the hanging maneuver. How do we hang the liver? Which were discussed in a previous class. What is the advantages of hanging the liver? So if you're not taking control of the hepatic vein, so it's a good idea that during anterior approach, what we do is just we make a plane above the IVC and hang the liver like this. Okay, between the right vein and the middle vein. Okay, so once we hang the liver, you have a sense of control about the middle hepatic vein and the right hepatic vein, and then you know the line of transection also. Okay, so that is what we do. So in anterior approach is generally we use the hanging way of liver, But we can use hanging approach in all of the conventional hepatectomy. So nowadays they use it even in your conventional hepatectomy. People like to hang the liver, but that was initially described with anterior approach only. And it's also the surgeon who proposed the liver hanging maneuver. That was Belghiti. Okay, Dr. Belghiti. Okay. So this is the extra thing that you should know about how do we do a liver transaction. So this is the anterior approach: inflow control, line of demarcation, parenchyma transaction, outflow control, and mobilization. When do you do that? If you have a large SCC and there's a risk of tumor spillage, bleeding, or fracture of the tumor. What about parenchyma preserving non-anatomical resection? So thing that we were discussing in a classes about your mini mesohepatectomy or your transverse hepatectomies. Okay, so where what we do is a anatomical resection. So that is a non-anatomical resection. Why? Because we're not going through a conventional liver planes. Okay, so we are not following the Conant system of segmental anatomy of the liver. So that is a non-anatomical liver resection. So what we do in your parenchyma preserving liver resection, we use intraoperative ultrasound. Okay, so that is a solely a IO intraoperative ultrasound guided resections. Okay, so where we mobilize the liver, but we don't have any inflow control. Suppose you have, this is the liver, and you have a small liver metastasis in segment 8 of the liver or segment 7 of the liver, and it is a colorectal liver metastasis, and you just want to do a wedge resection or a simple metastastectomy, then you don't have to do a proper right hepatectomy here. You just have to remove this lesion with a R0 margin. So that would be a non-anatomical resection. Okay. How to do that? Non-anatomical, we don't have any inflow control here. So what we do is we put the ultrasound probe and then we mark this margin. Try to get a R0 margin here and straight away go inside. Okay. In the parenchyma, we start cutting the parenchyma, and whatever pedicles you get during your liver coring, you ligate all these pedicles, whatever they are feeding the tumor. And in the end, we remove the tumor. So if you are near the middle hepatic vein, then obviously this is what your mini mesohepatectomy is about. So if you have very central placed tumor where it is near the middle hepatic vein, we use the liver tunnel approach that was asked in one of your papers, where it was basically first described by Torricelli. Okay, so what he uses the plane between right and middle hepatic vein, where we loop the middle hepatic vein initially to have venous control, and then we transect this your whatever tumor you have, and depending upon the involvement of the middle hepatic vein, you can resect the vein or you can leave the vein. So initially you have venous control because that is where the source of bleeding is. Okay, so 3 ways of transecting the liver: the normal anatomical approach, then you have the anterior approach, and then you have the parenchyma preserving non-anatomical resection. So there's a question on which of the following is the most appropriate bariatric procedure in patients who have significant GERD. So this is again a repeat question, have been asked multiple times. So we know that patients who have a very high level of GERD, we do a Roux-en-Y gastric bypass. Okay, so why is that? Because we know if you do a simple sleeve gastrectomy, then your intragastric pressures are very high and the reflux will increase. Okay, reflux will increase. So the best way to tackle patients with morbid obesity with GERD is to do a Roux-en-Y gastric bypass, because in this way you are isolating the stomach from the rest of the acid producing area. So this is the majority of the acid producing area. So here you are transecting the stomach, you have a very small gastric pouch, and this is being anastomosed with the jejunum. Okay, Roux-en-Y loop of jejunum. Okay, so that is why this is the most definitive procedure for GERD in patients who are morbidly obese. So how do you screen for that? So all patients are obese, so they will have some amount of reflux. So it does not mean that all patients should undergo a Roux-en-Y gastric bypass. So that is why we do a upper GI endoscopy in all the patients before surgery. So if you have any evidence of esophagitis, okay, so if you have any evidence of esophagitis, then we do a 24-hour pH study also in this patient. So we have to prove that this patient has GERD. Otherwise, most of us will have some amount of esophagitis. It doesn't mean that all patients should undergo a Roux-en-Y gastric bypass. So only if you have significant GERD, so if you have LA grade C or grade D esophagitis, then only it makes sense to do a Roux-en-Y gastric bypass. Otherwise, sleeve gastrectomy is a very well tolerable surgery. All right. So this basically is mentioned by all your standard textbook. So if you read your Sabiston or Bailey and Love, they have written that immediate resolution of symptoms of GERD is seen in more than 90% of cases in Roux-en-Y gastric bypass. And this is due to the small gastric pouch, which has a limited reservoir for holding gastric juice. And cardia is basically is not an acid producing area of the stomach. Okay. So that is again the concept that is often been asked in your previous papers also. So this becomes a very easy question. Now coming to this question, so there are two questions on mesenteric ischemia, I feel. So this is a 40-year-old patient, has sudden onset abdominal pain, and on examination, abdomen is soft and non-tender, and this is CT scan finding. Patient has bowel edema, mesenteric enhancement with some air pockets. He had dysentery 2 days ago, okay, which resolved spontaneously. What is the most likely diagnosis? Okay. So we have to first screen all the options. So we know what is it, but obviously we have to see all the options and rule out all the options. So this patient, if you want to analyze this question, so this is a 40-year-old patient, has abdominal pain. So what is the first clue that the examiner is giving you? He's saying that abdomen is soft, but it has sudden onset pain. So it's basically pain out of proportion of physical findings. Okay. So if you have patient has abdominal pain and physically finding is that abdomen is soft and non-tender, so that is the first pointer the examiner is giving you. Okay. So that is very classical of acute mesenteric ischemia. Okay. So here only you can get the right answer. So patient has abdominal pain that is out of proportion of the physical finding. It means that patient has acute mesenteric ischemia. And then you have CT evidence to prove that. So you do a CT scan, there is bowel edema and mesenteric enhancement with air foci. So that is early signs of mesenteric ischemia. So early signs of mesenteric ischemia, you will see there will be bowel edema and you may have some air foci. So it can be typical of pneumatosis. So we know that in mesenteric ischemia, you have some amount of pneumatosis also. Okay. Now here the question is, if they ask about etiology, so if you have two options here, so it can be definitely it is acute mesenteric ischemia. See if they ask you whether it is arterial or venous, then it will be a better question, I feel. So if you have an option like acute embolic mesenteric ischemia or mesenteric venous thrombosis, so this is the pointer here. If a patient had dysentery 2 days back, so it points more to a venous thrombosis. Okay, so this patient most probably has a venous thrombosis. So 3 points you have to look at. If this patient has a history of arrhythmia, so sometimes they'll give you a old patient, smoker, diabetic, hypertensive, has history of arrhythmia, and then he lands up with acute mesenteric ischemia. So that is an arterial embolic phenomena. Okay, this is more likely due to aftermath of chronic dehydration. Okay, so that looks more like a mesenteric venous thrombosis due to dehydration. So due to dehydration, sometimes it happens in very warm tropical climates where patient had dehydration, and due to sometimes they have underlying prothrombotic state as well. So due to all these things, they can land up with your venous thrombosis. Okay, so it may happen, and if especially if you have a prothrombotic state. So whenever you have a patient with mesenteric ischemia, these are the pointers where you have to look at. So clinical features, physical examination, CT findings, and what is the precedent event. So how does this event happen? Is this an embolic phenomena or it is a venous phenomenon? So there also they can be asked questions. So why is not fulminant colitis? Generally, these patients will have some amount of bloody diarrhea and fever is a very prominent symptom of colitis. So this patient is not having any fever. Okay. Mesenteric ischemia is obvious diagnosis. Amoebic colitis, again, they will have a long history of fever and abdominal diarrhea, abdominal pain. So it's not amoebic colitis. C. difficile, you should have a proper setup for C. difficile. So generally, patients who are in ICU, who are old age patients on antibiotics, and they will have watery diarrhea. Okay. So this is how a C. difficile will present. So all depends upon the background clinical scenario. So if you have an old patient in ICU who has diarrhea on antibiotics, then you know that it is C. difficile. Okay, a young patient coming from a say endemic area has diarrhea and all, so we know it is a case of amoebic colitis. So you should know the background presentation of these typical clinical manifestations. Okay, so next time they came ask you about amoebic colitis also, and they had asked one question about C. difficile also. So you should know classical presentation of all these prominent colitis. So this was one more question. So patient with AF treated with antiarrhythmics now he has abdominal pain. So we know it is a mesenteric arterial embolism. Okay, so this is a straightforward this thing diagnosis. But again, you can be asked such type of options in this question also. So suppose they had given mesenteric arterial embolism, mesenteric venous thrombosis. So now how will you decide whether it is embolism or thrombosis? So there we have to see for the clinical symptoms or some background history that the examiner will give you. Okay, so some the classical history is patient with AF has sudden onset abdominal pain. The moment you see that AF with abdominal pain has to be an embolism. Okay. So severe pain out of proportion of clinical finding, hallmark of acute mesenteric ischemia, because early in course your peritoneal signs are absent. What are the events that lead to this event? History of arrhythmia, atrial fibrillation, arterial thromboembolism, recent diarrhea, dehydration. What are the CT findings? These are kind of non-specific in the initial period. Later on, you have this frank necrosis. Okay. So severe pain, soft abdomen, ischemic findings on CT scan is mesenteric ischemia. This is how you diagnose mesenteric ischemia. Why is not fulminant colitis? So this is how a colitis will present. So they will have diarrhea, fever, pain, no signs of ischemia. So this is how we will differentiate. CT scan, you will not see any signs of mesenteric ischemia. Even in amoebic colitis, you will have fever, diarrhea, pain, but colonic colon will be involved, but no signs of mesenteric ischemia. C. difficile, patients has profuse diarrhea, marked tenderness, and you'll have thickening in the colon. Okay. Now, there's a question about your drainage in pancreas and kidney transplantation. True statement about enteric drainage in simultaneous pancreas and a kidney transplantation. Okay. Now, there is a controversy whether you should, suppose we have done a pancreas transplantation and we know that the duodenum comes along with the pancreas like this. Okay. Now, where do you drain this? So, we have two options here. Either you can drain this into the bladder or you can drain this into small bowel. Mostly it is a jejunal loop. Okay. So initially people were very fond of doing a bladder drainage. Okay. So joining this thing upside down like this. This is the bladder and this is the pancreas. This is the duodenum. This is the pancreas. So you used to join this pancreas with the bladder. Why was that? So now this is not the natural drainage of pancreas. Natural drainage of pancreas is always the small bowel. So why is that? Number one, initially people were quite afraid of a bowel leak. Okay, so because this is a very precarious anastomosis, so in the event of a small bowel leak, so that can lead to sepsis, and these patients can die very rapidly because of the immunosuppression. So to prevent that thing, they thought that why not join this thing with the your bladder. Okay, so that was the initial thing. It's not written in the books. That is how it started with. Advantage, second advantage was that through this bladder bicarb concentration, they could monitor the function of the pancreas, and indirectly they could monitor rejection also in these patients. Okay. The two advantage. One was that even if it leaks, then it is not a big issue. Second thing, because of the your bladder bicarbonate levels, urine bicarb levels, you can monitor the function of the pancreas. The problem with this drainage was that these patients were having a lot of cystitis and UTI, and that was causing damage to the kidney because we have done a kidney transplant also because of recurrent UTI and cystitis. The kidneys was taking a hit. Second thing, you're losing a lot of bicarbonate, so that was causing metabolic acidosis. So now what is happening is now we are shifting back to your original physiological drainage. So now we are doing this this anastomosis with the small bowel, either with the loop of jejunum or a Roux-en-Y loop of jejunum. Okay. Now the question was about your this thing. So now what happens is, suppose you have done a bladder drainage and the patient is not responding to your bladder drainage, is having recurrent this thing, UTIs and everything. So then you revert back to bowel drainage. So what the time frame of reversal is basically at least 1 year, not before 6 months. So generally, once you do transplantation, even after you want to revert back, it will be after 6 months. All right. So this is taken from straight away from your books, Bailey and Love. This is your bladder drainage where your duodenum is joined with the bladder. And this is your enteric drainage where your duodenum is sutured to the small bowel. Okay. And we know the advantages and disadvantages of enteric and bladder. If they ask you what is the current standard of care, it is enteric drainage. So we prefer to do enteric drainage rather than a bladder drainage because of the obvious reason just I mentioned. Okay, so these are differences. So what is bladder drainage? It is an older traditional technique, easy monitoring because you can monitor the urinary amylase and bicarbonate function. So you can indirectly basically monitor the pancreas function, early detection of rejection, and it is obviously non-physiological. Metabolic acidosis because of loss of bicarbonate. You'll have urologic complications. You'll have hematuria, UTIs, nephritis, cystitis, reflux pancreatitis. The urine can go back into the pancreas, cause pancreatitis. And there's a need for secondary surgery. Quality of life is not good. There's a risk of dehydration because of bicarb loss. And you can have anastomotic complications. Okay. And the current usage generally we don't use now. Okay. So only advantage is easier rejection monitoring. Okay. And here it is the physiological thing. It is the current standard technique. Okay. Only thing is that you cannot monitor your this thing, your bicarb and serum, your lipase and amylase levels. So about the timing of your drainage, so if you read Billy and Love, they have written that it is usually delayed until one year post transplantation. Okay, so if the patient is not tolerating your bladder drainage, so what they do is they again do a laparotomy and the duodenum is disconnected from the bladder and the bladder is closed in two layers and any adjacent section of the small bowel is identified and the anastomosis is done with the duodenum. Okay. See here they have mentioned the disadvantages of a bladder drainage. So patients will have acidosis, they will have cystitis, they will have nephritis. So all these problems are there. Okay, so that is why the current standard is to do a enteric drainage. If a patient has undergone any bladder drainage, then after 1 year we go back to your enteric drainage. So this is again a patient, see elderly male ICU admission, intractable diarrhea, second day of admission, leukocytosis, thrombocytopenia. So this is a very classical setting for a C. difficile diarrhea. Okay. Now you may argue that why is not Campylobacter jejuni or CMV diarrhea? So all these have the same presentation. They may have leukocytosis, thrombocytopenia, but we have to see the background history of the patient. So we know that C. difficile is more common in elderly patient, ICU admission, and on antibiotics. C. jejuni is basically is a community acquired diarrhea. Okay, and they generally these patients will have some amount of dysentery as well. Okay, C. difficile by nature they will have watery diarrhea. Okay, CMV again it will present in patients who are on immunosuppression. Okay, so it affects the colon, and then we'll have a bloody diarrhea. Okay. Staph aureus is basically a classical history. Boys going to picnic, kids going to picnic, and then you have a sporadic outburst of diarrhea. So that is how your staph diarrhea is like a pandemic, local outbreak of diarrhea due to some food poisoning. Okay, so this is how we have to if this question was like children went to picnic and then when they came back to home, these people are having loose stools, then you can think of a staph origin, that is a local outbreak of diarrhea. Okay. So this is how we have to see. C. difficile, elderly age, ICU admission, broad spectrum antibiotics, intractable watery diarrhea, marked leukocytosis. C. jejuni, gastroenteritis, fever, bloody diarrhea. CMV in immunocompromised patients. Staph aureus, food poisoning via toxin. They will have acute vomiting and diarrhea. So always, whenever you have a situation like this, even if you have, say, mesenteric ischemia, look at the background history of the patient. What is the information the examiner is trying to provide? Okay, and then you'll come back. You'll get the option in most of the times. Okay. So this was a question that we were discussing in the group: pan-esophageal pressurization with preserved peristalsis on your HRM. What is the probable diagnosis? And most of you had gone for type 2 achalasia. Okay, so this is not the right answer, I feel. Okay, so by definition, achalasia cardia will not have a normal peristalsis. So that is the basic definition of achalasia cardia. So how do we define achalasia cardia? By two ways. One is your absent peristalsis, okay, and that is more important than absence of relaxation of the lower esophageal sphincter, okay. So these two are prerequisite for diagnosis of achalasia, okay. So if you read your Chicago 3 classification, Chicago 4 classification, so these two has to be present. And if you want to choose any one of these between these two, then absent peristalsis is the hallmark, okay. So if you have absent peristalsis, then only you can label a patient as having achalasia cardia, okay. Now there's something called as achalasia in evolution, okay. So what happens in, if you see the Chicago 4 classification, so it's something called as esophageal junction outflow obstruction, okay, EGJOO, okay, esophageal gastric junction outflow obstruction, okay. So what people, some people say that this is kind of achalasia in evolution. So what is the clinical scenario of outflow obstruction? So in patients who have, say, long-standing reflux disease, patients who have, say, your this thing, eosinophilic esophagitis. Okay, so if you have any esophagitis, long-standing injury to the esophagus, so which slowly what happens is that they go on to develop achalasia cardia. Okay, so there's injury to the muscular wall of esophagus, and they go on to develop achalasia cardia. Okay, so that is what this is. So if there was no relaxation, so I'm coming to that. I'm coming to that. Your relaxation point, I'm coming to that. Okay. So what, suppose if I take your point also that they had mentioned about non-relaxation of your lower esophageal sphincter. Okay. So if you read the Chicago 4 classification, this is how they have tried to classify your motor disorders of esophagus. So the first branch point is basically your absence of relaxation of the lower esophageal sphincter, okay, LES. Okay, so you can divide your motor disorders into two subtypes: disorders where there is absence of relaxation of LES, and disorders where your LES relaxation is present. Okay, so this is the first point of differentiation of the motor disorders of esophagus. You look at the LES pressure first. Okay, is the LES relaxing? Is the LES not relaxing? So you have two set of disorders. So in this first set, where your LES is not relaxing, again you have two disorders. One is your achalasia cardia, and other is your, this is a newly coined term, is esophagogastric junction outlet obstruction. Okay. Now, how to differentiate this between these two, achalasia and outflow obstruction? Look at presence of normal peristalsis. So these patients will have absent peristalsis, and these patients will have normal peristalsis. Okay. So if you have a patient with normal peristalsis with absent relaxation, that is esophagogastric junction outflow obstruction. Okay. If a patient has absent peristalsis and absent relaxation, then it is achalasia cardia. Okay. This pan-esophageal pressurization, if you see, it is there in almost all types of achalasia cardia. It is kind of pathognomic for type 2, but it is not specific for type 2. You can get PEP in type 1 also, in type 3 also, even in your outflow obstructions also. So that is not, a diagnostic criteria for a type 2 achalasia. Okay. So this is what the examiner was trying to check. Okay. Yeah, so this is what is the problem, that they had written again achalasia cardia. So that is not true. Okay, so if you are writing that patient had preserved peristaltic vigor, where they are clearly stated that the peristalsis vigor is normal, then you cannot have achalasia cardia. Okay, so you cannot have a preserved peristaltic vigor with, and then you label it as achalasia cardia. By definition, achalasia cardia, the peristaltic vigor is not preserved. It is absent peristalsis. Okay, that is a definition of achalasia cardia. So if you read your Bailey and Love, and this is your Chicago 4.0 classification, so this is what they have done. So if you first think what you see is your medium integrated relaxing potential, and that is measuring your lower esophageal sphincter. Is it elevated? Is it normal? If it is elevated, then we look at 100% absent peristalsis. If you see, this is the branch point. 100% absent peristalsis. Okay. If it is present, then you have achalasia 1, achalasia 2, achalasia 3. So here we have 100% absent peristalsis. There is no panesophageal pressurization, no POP. In type 2, you will have POP. Type 3, you will have premature contraction, high amplitude premature contraction. Okay. So if you see more than 20% swallows with premature contraction and failed peristalsis, POP may be present. May be present. It's not that it's only present in achalasia 2. In achalasia 2, it is most commonly present. So if you see 100% failed peristalsis with POP in greater than equal to 20% swallows. So if you have POP in more than 20% of swallows with obviously absent peristalsis, then it is a type 2 achalasia cardia. Okay, but we have to look at the first branch point. So absent, your relaxation is not there because your IRP is elevated, and you have 100% absent peristalsis. Then only you go into the second branch point. You look at various types of achalasia cardia. If it is not satisfied, okay, then you look at this thing. So this is the outflow obstruction. For that, we have some other tests available. That is the TBO test or flip test. Okay, so that is measuring the impedance of the esophagus, how compliant the esophagus is. But the basic difference is you look at your peristalsis. Okay, here also your IRP is elevated. The sphincter is not relaxing, but there is some contraction in the esophagus, and that is why some people label it as achalasia evolution. So if the esophagus wall is still intact, okay, it is still able to contract, it is still able to generate some amount of normal peristalsis, but the LES is not relaxing. Okay, with time the injury will just go on and go on, and this will go on to form achalasia cardia. Ultimately it will lose all its contraction, and when it loses all its contraction, then only we label it as achalasia cardia. Okay, so that is one difference that we have to understand. Okay. This is how we differentiate achalasia cardia, absent peristalsis, non-relaxation, okay, and outflow obstruction, non-relaxation with preserved peristalsis, okay. Failed poem, next best step in management. Okay, again, this was a controversial question. So if a patient has undergone, say, a patient has achalasia cardia, and nowadays all achalasia cardia primarily go to your gastroenterologist. Okay, if they are able to do a poem, then most of these patients will undergo a upfront poem. So if the patient goes to a surgeon, obviously he'll do a surgery, but primarily they go to gastroenterologists because they have dysphagia. And if they're diagnosed with achalasia cardia and if they have the expertise to do poem, mostly they will do a poem in that patient. So that is a very normal scenario that we come across where you have poem and it is not working. All right. So why do you have failed poem? So you can have two reasons why poem is not working. Number one, your myotomy is not good because maybe due to technical reason the your intervention, your gastroenterologist is not that confident and he has not done a good myotomy. Happens with your Hellers also. If you're not done a good myotomy, then they will have recurrence of dysphagia. And second thing, you'll have reflux. Okay, we know that in poem you'll have a lot of reflux, and it is statistically more than your Hellers myotomy because we're not doing any fundoplication. So your procedure can fail due to two reasons: insufficient myotomy or a lot of reflux. Okay. Then what is the treatment for a failed poem? So then you have all options available. So you can, in very high volume centers, you can do a redo poem also. So what is the problem with redo poem? So what happens in poem is that we go from the mucosal side. Okay, suppose this is the esophagus. So we go from the mucosa, we go in the submucosal plane and then do the myotomy like this. Okay. So once you have breached that plane, so you have already gone into that plane, then they will have fibrosis. Okay. And it is very, very difficult to go back in that plane again. Okay. So what we do is a posterior poem. You can go back in this wall and do the myotomy. So you can always do a posterior poem. Okay, so that is one option that you can exercise, do a posterior poem, but they have written redo poem. Okay, so again, this is, we have to again see whether this option fits into the right option or not. Okay, but again, doing a redo myotomy from that earlier point of myotomy is a very difficult job because of loss of this natural plane that was there. Okay. Second is laparoscopic Hellers myotomy. The advantage of this Hellers myotomy is that you are going through entirely normal plane. Now you go from outside in, not from inside out. Okay, so you'll have a plane to work with. Okay, so initially it was from inside out. Now we go from outside in. So you have a plane to work with. So that may be a good option. And then you are adding a fundoplication as well. You take care of the reflux also. So that may be a good option for that patient. Medical management obviously will not help because this patient is requiring some intervention. Or second is some people also do pneumatic dilatation or esophagectomy. So all options are true. So depending upon the condition of the patient, you can think of even pneumatic dilatation also. That also may help this patient. But if they ask you what is the best management, then it has to be a surgery. That should be a Heller's myotomy. And if it is not working, then patient will go for a esophagectomy. So that is a definitive treatment of achalasia cardia. We just remove the esophagus. Okay. But it becomes very radical for a benign disease. So that is why we have to use all your non-invasive ways, in the sense that minimally invasive ways. So if poem is not working, we do a Heller's myotomy. It's the vice versa also. If you've done a Heller's and if it is not working, you can do a poem in that patient. The same concept applies here also. If you have done a poem, then you can do a Heller's. So that is how it is. So we know that indications of poem is a failed Heller's. This is what your books will write also. So same way, if the patient has undergone a poem and if it is not working, then you can always do a Heller's myotomy. Okay, so this is a simple way of putting things. Okay. So reasons for failure is reflux, incomplete myotomy. Your surgery will allow that access to myotomy from extraluminal site, which is a virgin plane. It will also allow your fundoplication to happen. So all, it's not that only the myotomy can be cause of failure. You can have a failure due to reflux also. Okay, so this is how it is. Failed Heller's poem, failed poem, you can do a Heller's myotomy. Problem with the redo poem is technically difficult and you have submucosal fibrosis, altered anatomy. So there's a risk of perforation. Okay? So it's not considered a salvage therapy. So this question, patient presenting with bleeding duodenal ulcer, unstable patient. You have done an endoscopy and it is not working. What is the best step? So this, I think we have extensively discussed in our classes. This was a very expected question. So this is how it is. It is a very simple thing. A patient who is coming to you with a bleeding duodenal ulcer, unstable patient, and your endoscopy has failed. So the best would be just open up the duodenum, suture ligate the vessel. Okay. Nothing else is required. So, okay. So what we do is we do a pyloromyotomy. So this is the, generally it is the bleeding point is the GDA, gastroduodenal artery. So we'll open the duodenum, and if you've read your books, they have described a U stitch. So where we stitch the gastroduodenal artery, we stitch the transverse pancreatic artery. Okay, we open the duodenum, we stitch the gastroduodenal artery, and then we close the duodenum in a horizontal way so that we don't have a narrowing of the duodenum. So that is basically a pyloroplasty. Okay, so that should be the most simplest way to deal with unstable patient. Okay. Now, what the books say that in your bleeding duodenal ulcer, there is a risk of recurrence if you don't do a vagotomy. So if the patient is stable, then we do a truncal vagotomy as well. Okay. So whether you do a truncal vagotomy, whether you not do a truncal vagotomy, all depends whether the patient is stable or unstable. If you're a stable patient, then you take care of the bleeder and then you add a vagotomy as well. So truncal vagotomy with pyloroplasty is the most common surgery done for a bleeding duodenal ulcer. All right, you got that? Now, what about antrectomy and truncal vagotomy? Okay. So if you read your chapter on peptic ulcer disease and surgery for peptic ulcer disease, so this is also we have to entertain sometime. So sometimes the examiner may ask you about your antrectomy also. So what is the indication of doing antrectomy with vagotomy in a patient with bleeding duodenal ulcer? It's not that this surgery is not done. It is done in some patients. Okay. So number one is obviously patient should be stable. Okay. Patient should be hemodynamically stable to tolerate extensive surgery like this. Okay. Number two, this patient is kind of a refractory patient. Okay, so patient is a known case of peptic ulcer disease. He has received treatment for H. pylori. Okay, so already patient has received treatment for H. pylori multiple times and he has failed treatment. So this is a patient who has refractory peptic ulcer disease. Okay, so refractory peptic ulcer disease, number one. Okay, or a patient who is basically NSAID dependent patient. Okay, so patient is a known case of rheumatoid arthritis, and you know that in future he will take NSAID because of his pain and all. Okay, so patients who have this kind of disorders, so peptic ulcer disease, not responding to medical therapy, received anti-H. pylori treatment before. So basically, you have classified as refractory PUD. So here you want a definitive surgery. Okay, and we know that the definitive surgery for acid reduction is antrectomy with vagotomy, because this will have the maximum effect on acid secretion. Okay, maximum effect on acid secretion. So you have two sources of acid, no? The antrum and the vagus. So you cut the two sources, the acid production will go down. Okay, but it is a very morbid surgery, so we don't do it routinely. So doing antrectomy in emergency setting is not advised. But yes, in certain group of patients, it becomes a very good surgery, especially in patients who have, suppose this was scenario, this patient is a 50-year-old patient, known case of peptic ulcer disease, received multiple treatments before. Now he has ulcer disease, as a duodenal bleed. Patient is stable, okay, and you want to have a definitive surgery. If they ask you what is a definitive surgery, then it would be antrectomy and truncal vagotomy. Okay. If they ask you what is the best surgery, if it is stable patient, so they change the question. If it is a stable patient, then the answer would be truncal vagotomy with pyloroplasty. Okay, that is the best surgery because vagotomy reduces the rebleed rates in duodenal ulcer. Okay, so that is why if you read your books, they advocate that you should do at least a vagotomy, at least a vagotomy. Okay, so what is the best surgery or the most common surgery in a stable patient with DU bleed? Has to be truncal vagotomy with pyloroplasty. Unstable patient, simple suture ligation. Definitive surgery has to be antrectomy and truncal vagotomy. Okay, so this is how we have to put these things. Okay. So this is what I have summarized: the management of duodenal ulcer bleed in a stable patient, unstable patient, and definitive surgery. So this again was a little bit controversial. A 65-year-old patient, diverticular disease, present with a 7 centimeter abscess, free intraperitoneal layer. Now, according to what the inputs that I received in the group, that some people said that fever was there, some people said that tenderness was there. I don't know what was the exact question. Okay. So if they had mentioned about free air, okay, with fever, with tenderness, then there's no confusion. This patient goes for surgery. Okay. So if we have free perforation with tenderness, with fever, then obviously he'll go for surgery and Hartmann's. Okay. So that is the best answer for this type of presentation. If they had just given that diverticular disease, 7 centimeter abscess, free air, soft abdomen, no tenderness, no fever. Okay, then this would be a different clinical scenario. So in these type of patients, you can give a trial of conservative management, where you just treat the percutaneous abscess with PCD, give antibiotics, and then obviously you do the your colectomy later on. Okay, so this can be tried, but no, localized quadrant obviously will not become an indication for surgery. It has to be a generalized peritonitis. Okay, so obviously a tenderness, point tenderness cannot become indication for surgery. Okay, it has to be generalized tenderness. But fever, yes, it should be a indication because that is one thing that can drive sepsis. Okay, so if they are giving free air with fever with tenderness, he goes for surgery. Free air, no tenderness, no fever, soft abdomen, then you can try this conservative management. Okay. So if you have such type of question, obviously you have to first see the Hinchey classification, and this belongs to either stage 2 or stage 3. But if you see stage 3 is generalized purulent peritonitis. So how to define peritonitis? The question is how to define peritonitis. Do you define peritonitis on the basis of just free air? I don't think so. So you have to define peritonitis on clinical, science and radiological science. Okay, so clinical, if the patient has generalized guarding, generalized rigidity, then you define peritonitis. Okay, on CT scan, if you have free air along with ascites and generalized collection, not a specific site of collection. If you have multiple collections in the abdomen with free air, then it is peritonitis. Okay, so you should know how to define peritonitis. It's not free air. Free air you can have with even your, if you have a large abscess in the liver and it ruptures, if it gets infected, you'll see air in the abdomen. It doesn't mean that the patient has peritonitis. Okay. Generally, in contained perforation also, you'll have some amount of free air. Even post-operative patients, because of the drain, you may see free air for say 3-4 days. It doesn't mean that the patient has peritonitis. If you have an anastomotic leak, if it is a contained leak, say you have done a colocolic anastomosis, patient has a leak, but it is a contained leak. Okay, you see some amount of air in the abdomen because of the leak, but the patient does not have any peritonitis. There's no fever, abdomen is soft, he's passing stool and flatus. What do? Do you operate in this patient? No. We just observe and watch. Sometimes it will be sealed off. Okay. So free air is not an indication for surgery, number one. So indication of surgery is they have written generalized peritonitis. So you have to define what is generalized peritonitis. It's not just, we cannot just treat the X-ray or the CT scan. If the patient is clinical, and peritonitis is the clinical diagnosis for that matter. Okay, always remember, peritonitis is not a radiological diagnosis. So they have to give some information. So they have to say that patient has high-grade fever, patient has instability, patient has generalized guarding or rigidity. Then only it is peritonitis, because you cannot differentiate purulent peritonitis from feculent peritonitis preoperatively unless until you go inside. Okay. So once you open it, then only you'll know whether it's purulent or feculent. The next way is just put a needle in the abdomen and then aspirate it. See it is purulent or feculent. Okay. So that is one way of confirming, but the best way is once you open the abdomen. Okay. So if you do a CT scan in these type of patients, purulent peritonitis, what will you see? You'll see generalized ascites. Okay. So you'll see ascites all over the abdomen. You'll not see a localized fluid collection in purulent peritonitis. Okay. Generally, you'll have gross ascites and you'll see collections here and there throughout the peritoneal cavity. Okay. So if they're saying that the patient has a pelvic abscess, okay, and there is some air in the peritoneal cavity, abdomen is soft, there's no tenderness, there's no fever, then I think the answer should be just drainage of the pelvic collection, and then you wait for the patient to improve, and then you do a colectomy later on. Okay. If they're saying that patient has generalized guarding, rigidity, and all those things, then it makes sense for a surgery. That is my understanding. Okay. So just presence of free air should not be indication for surgery. Okay. So if you read your Bailey also, they have clearly written that in very few selected patients, completely stable patients with diverticular perforation with distant pneumoperitoneum. Okay. So they have pneumoperitoneum, non-operative management with antibiotics, bowel arrest, and possible percutaneous abscess may be an option. Okay. So they have written here that even if you have free air, distant pneumoperitoneum, you can still try non-operative if the patient is stable. Okay. So how do you see? So if you see signs of sepsis include fever, tachycardia, hemodynamic instability, imaging, you'll see free abdominal fluid, signs of peritonitis and free intra-abdominal air. Okay, so this is where your controversy is. Okay, but you don't have to look at only free intra-abdominal air. Also, you have to look at free fluid, signs of peritonitis. This is the last that comes. Okay, so in carefully selected patients, even if you have free air, distant pneumoperitoneum, you can still give a trial of conservative management. Okay, have you understood this? So always, whenever we have this question, look at the uh, information that the clinician is giving you. Generalized tenderness, unstable patient, high-grade fever, it becomes indication for surgery. Okay. But if free air was not there, then it is a straightforward question. You just drain the abscess, antibiotics, and a colectomy later on. Okay. The confusion has come because they have given free air as one of your options. Okay. So the following is not an indication of bariatric surgery. So now the indications for bariatric, so this is a very easy option. A depressed patient obviously will not operate. So one of the indications for pediatric surgery, apart from your classical indications, is that patient should be motivated for the surgery. He should not have any psychiatric illness. He should not have any drug dependence, because we know obesity is a problem of some people are addicted to eating. Okay, so they like eating. So you have to counsel the patient that after surgery you will just not be able to eat, and that is one thing that has to be driven to the patient. So you cannot just do a bariatric surgery and hope that the patient will cooperate after surgery, because some people start eating after surgery and they will have again gain of weight and the surgery will fail. So that is very, very important, that patient has to be motivated and there should be some social support, and they should not have any drug dependence, psychiatrically stable. Okay, so that is an absolute contraindication for surgery, for bariatric surgery. The patient is not willing for that kind of life later on. Okay, so number one, this is obviously a contraindication. Now, if you see this BMI thing about your bariatric surgery, so now if you read your recent guidelines, so they have clearly stated that if a patient has a BMI of more than 35, he goes for surgery. Okay, earlier it was more than 40 and 35 with some comorbid illness. Now they're saying that more than 35, he goes for bariatric surgery. More than 30 with diabetes, he goes for bariatric surgery. Okay, so because of the metabolic effect of that surgery. Okay, so more than 35 goes for upfront surgery, more than 30 with some comorbidities go for surgery. In Asian patient, they are saying that if it is 25, 30 also, and he has diabetes, he also goes for surgery because of the metabolic effects of the surgery. Okay, so this, I think they have slightly changed. In Asian patients, even if your BMI is more than 25, between 25 and 30, and if you have diabetes, then it becomes indication for surgery. All right. So this was the earlier NICE guideline that was in 2014, but now you have all these new guidelines. So BMI of more than 35 or BMI of more than 30 with an associated medical comorbidity. So earlier this was 40. Okay, earlier this was 40. If you read this was the previous guidelines, more than 40. But anyone with a BMI of more than 35 goes for surgery. BMI of more than 30 with a comorbid illness goes for surgery. In Asian patients, again, the cutoff of BMI is slightly lesser. So these are other indications: failed dietary therapy, psychiatrically stable, without any drug dependence. He should be knowledgeable about the surgery, motivated. Okay, so all these things are very, very important. Although they sound a bit of bookish type, but these are very, very important before you consider this thing, bariatric surgery. And if you read your books, they have mentioned other two conditions as contraindications. One is your Pickwickian syndrome, where patients have a you know tendency to overeat because of the hippocampus problem. So that is one thing. And if the patient cannot move in the post-operative period due to debilitating arthritis, inability to move. So these again two are contraindications for bariatric surgery. All right. About the age, earlier they used to feel that patients should not undergo surgery if they are less than 18 years old, but this is not true. So we have this teen study which they proved that even patients who are less than 18 with diabetes, you can go for surgery. The upper limit is 65, but on case-to-case basis, you can decide if it is more than 70 and the patient is fit for surgery, because nowadays we do robotic and laparoscopic, you can do a bariatric surgery. This is about gastric banding. After laparoscopic gastric banding, patient has worsening symptoms, and you do X-ray, you see the band in vertical position. What is the next step? So we know about gastric banding. This is a surgery which has the minimum morbidity initially. Okay, so initially it is kind of a very simple surgery. We go inside the abdomen, open the pars flaccida, and put a band below the GE junction like this. Okay, and then you have a axis thing. So if you inflate it, the band will tighten up. If you deflate it, the band will loose. And then you adjust this band along according to the eating habitus of the patient. So this is how it works. It basically constricts your G junction just below the G junction. Okay. Problem with these things is that this can slip or erode. Okay. So generally you can see on X-ray, it is like this. Okay, next so you'll see something like this. If it is goes vertical, it means it has slipped like this. Okay. So if the band has slipped, then the first step is you deflate the band. Because if you don't deflate that band, then it will compress the stomach and can have gastric necrosis. Okay. So whenever you have a slip band, the first thing you deflate the band. And then you decide whether you want to keep the band or remove the band. So that is a secondary thing. First thing is that you deflate the band. Okay. You cannot observe, because if you observe, this slip band can press and compress the stomach, and the stomach can go into necrosis. So that is the first thing that you do. Okay, you deflate the band. Okay. Now, what are the other problems with this gastric banding? Number one, due to this chronic obstruction at the GE junction, you can have motility disorders of esophagus. So you can have mega esophagus. Okay, if you do a manometry, you'll see some kind of motility disorder also because of the obstruction just below the G junction. The esophagus dilates. Okay, that is one problem. This band can erode into the stomach. So you have seen cases of gastric erosion and gastric perforation. Okay, so these are the problems. And second thing is that the weight loss is not that great. If you compare your gastric bands with sleeve gastrectomies and Roux-en-Y gastric bypass, this is the procedure which has the least amount of weight loss. So that is why this procedure has gone out of favor, because now we have good drugs to have weight loss. So there's no point constricting the stomach in the G junction and landing up with this complication, knowing that this will not help you to have a sustained weight loss. Okay. So this is how it works. You just go and compress the stomach. Okay, it's just squeezing the stomach below. Okay. So normal band position is a degree. This is called phi angle. Okay, and if this is disturbed, so normally it is like this oblique, and if it becomes slips, it becomes horizontal. Okay, vertical. Sorry. Okay. So if you have a band erosion, you have to remove the band. If it is a band displacement, you reposition it, deflate it, and then you can reposition it. This is because there's a risk of gastric necrosis. What are the other complications? You can have megaesophagus, pseudoachalasia, esophagus motility disorders, inadequate weight loss compared to other procedures, and most common cause of reoperation in gastric banding is inadequate weight loss. Okay. What is the advantage that among all these procedures, this has the lowest morbidity and mortality, 30 day, because it is a very simple procedure. So that is why the mortality and morbidity is lowest, but the weight loss, if you compare all these interventions, it has the least weight loss, gastric band. Okay, if you 3 year weight loss is 40 to 50%, others if you see is 50 to 60%. Highest is one anastomosis gastric bypass or BPD. So highest is with biliary pancreatic diversion. Okay, 70 to 80%. Okay. So these are the complications of the routine procedures that we do. So gastric banding, you can have slippage and erosion. Sleeves, they are more prone to have leak. And if you have pre-existing GERD, this can exacerbate. Roux-en-Y gastric bypass, they will have internal hernias and marginal ulcers. These are complications. One anastomosis gastric bypass, they will have bile reflux because of the jejunum that we have joined with the stomach. So you'll have bile reflux. And obviously, your biliopancreatic and duodenal switch will have protein energy malnutrition. So this is just a summary of important complications of all these procedures. Patient presents 6 years after. This is just a separate question to not asked. Actually, I just have framed it with progressive dysphagia and weight regain, and you do endoscopy shows gastric mucosa overlying the band. So this is a case of band erosion. And here, this patient requires band removal, not deflation. We have to remove that band, okay, because it has grown into the stomach. A post-cholecystectomy patient presents with jaundice and features of cholangitis. MRCP shows filling defects, basically stones in the CBD. What preoperative investigation is most important before proceeding to the procedure? So answer is straightforward, is obviously INR. But why do you want to look for INR, okay, in this patient? Number one, this patient has cholangitis and jaundice, okay, has CBD stone, okay, has cholangitis, and he has jaundice. We know in patients who have obstructive jaundice, they will have problems in vitamin K dependent coagulation factor. So they have elevation of prothrombin time. So that is why we give them vitamin K. Okay. So the INR may be deranged in patients who have obstructive jaundice. Number one. Number two, due to sepsis itself, you can have deranged INR. So INR can be deranged via two mechanisms. One is jaundice, another is cholangitis. Now, why do you want to look at INR, if at all? Because generally, if you're doing ERCP for patients with CBD stone, we don't do a sphincterotomy. So now here we have to understand what are the protocols for ERCP in patients who have cholangitis. So normally, if you do a ERCP and you want to remove the stones, so there are two ways of doing that. You do a sphincterotomy and then you remove the stones, or do a balloon dilatation, sphincteroplasty, and then remove the stones, because stones will not come in because the ampulla is very small. You have to cut the ampulla or dilate the ampulla, and then only your stones will come out. Now, what happens in patients with cholangitis? Generally, it is advisable that we don't do a sphincterotomy. Okay, we don't do a sphincterotomy because of these INR issues. Okay, so you can have bleeding from the sphincterotomy side. So in emergency ERCP, a routine sphincterotomy is not done. It's not done. What is the second thing that we have to understand? We should not try to do a stone clearance also. Okay, so in a patient who has undergone emergency ERCP for cholangitis, a stone clearance generally is not warranted. So all you want is biliary drainage. Okay, so you just put a stent inside. Okay, so you just put a simple plastic stent. So your primary objective in cholangitis is biliary drainage. So you should not do a sphincterotomy. We should not attempt a stone clearance. You have to just do a biliary drainage. What about cholangiogram? Okay, so generally we do a cholangiogram, we put a contrast and take a shot. So this all is done to see for stone clearance. So since we are not doing any stone clearance, a cholangiogram is also is not warranted. If at all you want to do, you do a very limited cholangiogram. So suppose you want to check your whether your stent is in place and you want to do a cholangiogram, you can do it with small amount of dye, or you can do air cholangiogram also. Okay. Sometimes they ask you in emergency ERCP for stone disease, what are the precautions you take? Routine ERCP we don't do. Okay, even ERCP is done by medical gastroenterologists, but still you should have a very basic idea about ERCPs. Okay, so what do you do in emergency ERCPs? So these are things, because this patient is in cholangitis, in sepsis. Okay, we don't have so much time to manipulate the CPD. So the patient has cholangitis, your only intervention should be have a biliary drainage. Okay, because of the issues I told you. One patient is in sepsis, the INR is mostly deranged. If you do a sphincterotomy, they will have bleeding from the ampulla, and you don't have so much time for all these things. The only thing that can is basically you have to do a life-saving intervention, and that will be a simple biliary drainage. Okay, a simple biliary drainage is all that this patient requires, nothing more than that. Okay, so this is a question that is often asked. So they will ask you that ERCP, you're doing ERCP in emergency, what are the things that you should do, what are the things that you should not do. Okay. So this is what we do. We do a ERCP stenting. We should not do a sphincterotomy. Okay. What is the goal is rapid biliary decompression with minimal trauma. Indication, moderate and severe cholangitis, and patient is not responding to antibiotics. So before ERCP also, you should have to remember a few steps. So you have to first give him IV fluids. Antibiotics is important. If the patient has hypotension, you have to start vasopressors as well. Correct the coagulopathy. So if the patient has cholangitis, it doesn't mean that patient, you just shift the patient for ERCP. So we have to first do all these things: hemodynamic stabilization, fluids, antibiotics, vasopressors. Also send a blood culture before starting antibiotics. Very, very important. Okay. Routine sphincterotomy should not be done in cholangitis, especially in severe cholangitis. Although in mild cholangitis, you can still consider a stone clearance, but in moderate and severe, you should not do a stone clearance and sphincterotomy. What we do is temporary biliary drainage with stenting, no cholangiogram because of risk of sepsis. What we do is wire-guided cannulation. Okay. So acute cholangitis, the preferred ERCP strategy is biliary stenting without sphincterotomy or stone extraction. That is very, very important to understand. Okay. So these are your what should be done, what should not be done. So wire-guided cannulation, minimal or no contrast, plastic biliary stent. And we should also understand what are the indications of a nasobiliary drainage. Okay, sometimes you have seen patients with a tube coming out from the nose. So in ERCP, if you think that the patient has white bile or pus in the CBD, so if you put a stent in patients who are very, very sick, okay, and you just put a stent there, so bile is very, very thick, this will block the stent. Okay, the stent will block in 24 hours. So for in these patients who have a very severe cholangitis and you do a ERCP, you see that there is white bile, it is just pus in the CBD, we put a nasobiliary catheter. So what is the advantage of nasobiliary catheter? You can flush that catheter. Obviously, number one, you can, so it will not block. So it will allow continuous drainage of the infected bile. So you can flush the catheter, you can obtain culture, and then you can do a cholangiogram later on. Okay, so it will help you do three things. It will prevent your blockage of the catheter because you can have access to the catheter, you can flush it, and then you can take cultures. And then you can do a cholangiogram later on when the patient is stabilized. So in very sick patients, we can do a nasobiliary drainage. Okay. So this is if during ERCP for moderate severe cholangitis, which is the preferred endoscopic strategy. Sometimes they can ask you this type of questions. So wire guided cannulation with biliary stent placement. This is what is required. Sphincterotomy should not be done. You should never give a full contrast cholangiogram. Balloon dilatation, stone clearance is not required. So in patients who have cholangitis, all that is required is a biliary drainage. That is a life-saving strategy. That is all that the patient requires. Okay. Patients with LA grade D esophagitis, hiatus hernia, normal motility, what is the appropriate management? Okay, so we know the answer is very simple, but we have to dissect why is this answer, why is not straight fix, why is not esophagectomy, why not tupid fundoplication? Okay, now this patient has a LA grade C and LA grade D esophagitis. It means that it is severe GRD. Okay, so we know that in patients who have LA grade C or LA grade D, we don't do a 24-hour pH study. It is not required. That is pathognomic of GERD. So LA grade C, LA grade D is GERD. So this is the first information that you have. Number one, this patient has a hiatus hernia and they have measured the defect also 3.5 centimeter. What is the importance of 3.5 centimeter? What if it was 1.5 centimeter? What if it was 2 centimeter? Okay, so how to interpret this? Okay, the third information they have given is normal motility study. Okay, so this patient has GERD. It has normal motility studies. It means that all patients of GERD need to have an HRM to look for any motility disorder. Okay, and it also has a hiatus hernia that is 3.5 centimeter. Okay, so this is a candidate for surgery. We all agree to that. Okay, so this is a classical candidate for surgery. What surgery? Obviously, he will require a fundoplication. Now what? Nissen or Tupid? We do Nissen because this patient has a grade D esophagitis with normal motility studies. So we do a Nissen fundoplication. Why not a Stitafix? This is also very attractive, it's RFA guided thing that we do for GERD. It is non-invasive, we don't require any surgery. So why not RFA guided or endoscopic management of GERD? Number one, he has a hiatus hernia. So once you have a hiatus hernia, you cannot do the hiatus induction via endoscopy. Okay, so that is one indication where you cannot do a Stitafix. Number two, you should not do Stitafix in patients who have a higher grade of esophagitis. So if he has C and D esophagitis, obviously we cannot do a Stitafix. So we do Stitafix in patients who have a very mild GRD, LA grade A or B, and a hiatus hernia that is not quite big, so less than 2 centimeter. Okay, this is where we do a Stitafix. Obviously, we will not do esophagectomy in these patients. Tupid, if the patient has some motility disorder, then we do a tupid fundoplication. So this is how we have to dissect all the options, and then because next time they will not ask the same question, they will twist the question, they'll give some other information, and then you should know how to interpret it and get to the right answers. Okay. So LA grade CD indicative GERD, motility is normal, so it tells you that you require a manometry before surgery. Hiatus hernia, indication of surgery type. So basically, if you have a hiatus hernia, and if it is a type 1 sliding hiatus hernia, You see many patients in OPD will come to your OPD with endoscopic report, and they will write the patient has a type 1 or type 2 sliding hiatus hernia, 2 centimeter, 2.5 centimeter. And these patients are very, very worried that this hernia is obviously a surgical thing. So they come to your OPD, that they'll give you a report that I have a sliding height. They must have gone endoscopy for some other gastritis or something like that, and they will come to you that I have a hiatus hernia. So hiatus hernia type 1, that is sliding, is not an indication for surgery. So when do you operate a sliding hiatus hernia? If the patient has symptoms. So what symptoms this patient will have? They will have GERD or reflux of food. Since the patient has sliding hiatus hernia with GERD, reflux of food, not managed by medical therapy, then it becomes indication for surgery. Where we reduce the hernia and then we do a fundoplication, all those things. So a simple sliding hernia is not operated for size. It does not matter what size is the hernia. If the patient does not have any symptom or symptoms are managed with medical therapy, it does not is not a candidate for surgery. Okay, so that we have to understand. Okay, so isolated hiatus hernia with no GRD, no surgical treatment. Okay. So not an indication for surgery is sliding hernia, asymptomatic small, hiatus hernia without reflux, and hiatus hernia less than 2 centimeter with controlled GERD. So small hiatus hernia, GERD control, is not an indication for surgery. So when do you use this data things? It's an endoscopic RFA thing, contraindicated in higher grade of esophagitis, and if your hiatus hernia is more than 2 centimeter. So there we should not use this data thing. Tupet, basically, this patient has normal motility. So generally we say that in patients who have normal motility, the esophagus wall, there's no problem with the esophagus wall motility. We prefer to do a total fundoplication, that is a 360-degree fundoplication. People say that that has the maximal reduction in GERD. Tupet is a partial fundoplication, it is not a complete fundoplication. So they say that the effects are not that good compared to Nissen. But we only do tupet if you have a motility disorder of the esophagus. Okay, so before completely wrapping the esophagus, you should ensure that this esophagus does not have any motility disorder. Because what happens after Nissen is, we know patients have dysphagia. Okay, and if the patient already has an underlying motility disorder, then the dysphagia will exacerbate. So that is why it's very important. We do a baseline manometry, and if the manometry shows that the motility disorder is there, then you do a tupet, partial fundoplication. Otherwise, Nissen is the gold standard. Okay. So this is what we do. Patient has, normal motility, we do a Nissen. Poor motility, we do a tupet. Short esophagus, we do a Colles gastroplasty with flap. Okay, so this is the basic information that we all know. How do we approach a patient with GERD? Which of the following criteria is considered unresectable? So this is a very easy question. Obviously, SMA encasement is unresectable. And these all are examples of borderline resectable pancreatic cancer. So this we all know what is borderline resectable and what is resectable as far as pancreatic cancer is concerned. So just we have a short revision. So if you want to define resectability in pancreatic cancer, so you have arterial definition, you have venous definition. Okay. Arterial definition is very simple. So if you're dealing with the head of pancreas, you have only two arteries to deal with. One is your celiac axis, other is your superior mesenteric artery. So any contact with the artery, if the tumor has any contact with the artery, it becomes borderline resectable. Okay. Now, what is the extent of contact? If the contact is less than 180 degree, it is borderline resectable. If it is more than 180 degree, then it is becomes a locally advanced pancreatic cancer. Now, note this term. What is locally advanced pancreatic cancer? Okay. So artery is very clear. Any contact less than 180 degree, it becomes borderline resectable. Any contact more than 180 degree, it becomes locally advanced or unresectable pancreatic cancer. With veins, there is a different story. So if you have a vein and if you have just contact with the vein, and if it is not distorting the architecture of the vein, so it means that the vein is not getting deformed, it becomes a resectable according to NCCN guideline. But if it is distorting the vein or if you have more than 180 degree contact, it means that the vein is completely involved. it becomes borderline resectable. So in veins, you don't have a entity such as locally advanced, but yes, you have. So if you have extensive venous involvement, suppose the superior mesenteric vein is involved, it is goes down into the jejunal vein and colic veins. So basically, if you have a cavernoma like this, so if we don't have a proximal and distal vein to join. So it is extensive thrombosis, extensive involvement. You don't have a target. You don't have this proximal target and distal target to join. Then also it becomes a locally advanced pancreatic cancer. It becomes a locally advanced pancreatic cancer. So why I'm emphasizing the term locally advanced pancreatic cancer is there's something called as metastatic pancreatic cancer. So you have three types of pancreatic cancer. So you have resectable, you have borderline resectable, and third is locally advanced, and then you have metastatic. Okay. So resectable, we all know about borderline resectable. Now we know this third category is locally advanced. So if you have a complete encasement of SMA, it is locally advanced. If you have a very wide, extensive range of venous involvement, such that you don't have a proximal and distal target, then also it is locally advanced. But these patients are not metastatic. It means you don't have any liver metastasis, you don't have any lung metastasis. In this fourth category, you have metastasis. So you have liver and lung metastasis. So this is the new category that is emerging, locally advanced pancreatic cancer. So what is importance of knowing that? Yes, you cannot do arterial resection here. The venous is not possible. So what they do is they give chemotherapy in these patients. So they give long chemotherapy. And with this chemotherapy, with 15%, again, they come back to borderline resectable. Suppose you have an arterial involvement of 360 degree. After chemotherapy, the arteries will separate and the involvement will come down. So with chemotherapy, some of the locally advanced patients can be resected. So that is why they don't label it as metastatic. Okay. So if once you have metastasis, then the patient goes to palliative chemotherapy. That is very true. But in these patients, you can still go ahead and resect some patients. So you should know what is unresectable, what is locally advanced, what is metastatic. Okay. So this is your, for reference, I've given the existing definition. You can go through it. We'll learn about it when we'll study pancreatic cancer. So, but this is what I wanted you people to understand. What is borderline resectable and what is LAPC? Okay, so LAPC is here. You have extensive arterial involvement, extensive venous involvement, but we don't have metastasis. And you cannot do upfront surgery. But yes, 15% of patients after giving chemotherapy, you can convert this LAPC into BRPC. Okay, so that is one concept you have to understand. And there's a third category that is metastatic. If you have metastatic pancreatic cancer, it means patient has liver metastasis, lung metastasis. These patients cannot be converted. So these patients go for palliative chemotherapy. Here you can give NACT. If your intent is for conversion, you can give chemotherapy in this locally advanced pancreatic cancer. So this is the new concept that you should understand about pancreatic cancer. Because all of you, we know about BRPC, but we should know also about LAPC as well. A patient with metastatic NET, profuse diarrhea, flushing, occasional wheezing, and this is not responding to antidiarrheal medicine. What is the pharmacological agent? So we know that this patient has a carcinoid syndrome. Okay, carcinoid syndrome. So what are the clinical manifestations of carcinoid syndrome? So generally these patients will have a rash. So that is the most common clinical manifestation. More than 90% of patients will have some amount of rash. Second most is diarrhea. Okay. And then may have abdominal pain or wheezing, all these things can happen. They can have cardiac issue. So they can have right-sided valvular abnormalities. So how do you deal with all these complications? So this is due to serotonin excess. So this is mediated by serotonin and all those histamines and all those things. Okay. So this is basically an enterokinin storm. So these patients are having all these clinical features. Now we have to understand in what clinical scenario this carcinoid syndrome happens. So this happens in patients who have extensive liver metastasis, because normally the liver will metabolize all your serotonin and histamine. So if your patient has a carcinoid syndrome, then obviously the liver is overwhelmed with metastasis, so it is not able to metabolize that. So that is again a bad prognostic factor. The second thing you have to understand about the differential diagnosis of diarrhea. This is very important to understand. So how do you differentiate diarrhea? Because previously, if you see, they have asked questions about diarrhea. So what is there in diarrhea about your this thing? carcinoid syndrome and neuroendocrine tumors. Because diarrhea, if you see, is a clinical feature of carcinoid syndrome, is a clinical feature of gastrinoma also. So how to differentiate a diarrhea of carcinoid syndrome from a diarrhea of gastrinoma? Okay, so there are very important differences, and the management is also different. So in gastrinoma, you have acid secretion, excessive acid secretion, and that leads to malabsorptive diarrhea. Okay, so this acid goes into the pancreas, into the lumen, it neutralizes all the enzymes. So you'll have something called a malabsorptive diarrhea. Okay. Here it is due to secretory diarrhea. So the serotonin is stimulating the cells to secrete water. So it is a secretory diarrhea. So it is a malabsorptive diarrhea due to acid hypersecretion. So how do you treat this thing? So you give PPIs here because acid is a culprit. So give PPI in high doses. We keep the patient NPO for some time. Okay. We keep the patient NPO, put a rice tube, you aspirate the gastric acid, give PPI. So this diarrhea will resolve. Okay. So this is a very, very important point to differentiate. Diarrhea in the context of gastrinoma or diarrhea in context of carcinoid syndrome. These patients are secretory diarrhea. So even if you keep this patient NPO or give them PPIs, the diarrhea will not resolve. It will just go on and on. So how do you do that? We give octreotide because we know octreotide inhibits the secretion of all these vasoactive hormones. Okay, so we give octreotide. So this you have to understand: diarrhea in gastrinoma, diarrhea in your carcinoid syndrome. This is very important to understand. Okay. So skin flushing is the most common sign, and you have diarrhea that is postparental and watery diarrhea. We have right-sided heart involvement. So the most common involvement is pulmonary stenosis, 90% with TIA. This is again a question that was asked a few years back. What is the order of involvement of the cardiac valves in carcinoid syndrome? So this is what I was telling you. What is secretory diarrhea and what is acid hypersecretion or malabsorptive diarrhea? Okay. So how do you treat that? Okay. This is octreotide and this is PPI. Okay. So this is very, very important to understand. What is the management? So you start with your long-acting somatostatin analogs, that is octreotide. But remember, this octreotide is basically, it has two effects. It is obviously anti-secretory. It is also anti-tumor activity. And we have the clarinet study to prove that it is has anti-tumor role as well. It decreases the, the tumor growth as well. So it has a negative effect on tumor growth. Basic work is obviously there. It will inhibit the release of your vasoactive amines. If it is not working, then we use your PRRT therapy, the peptide receptor therapy. You use this analog 177 lutetium 177. So you can give a targeted therapy to these patients. So this is a new drug that is approved that inhibits the synthesis of serotonin. So that is telostat. It is used in refractory diarrhea. Okay, so you have to understand this is the new thing that has come. So this is about management of carcinoid syndrome. There's something called as carcinoid crisis. Sometimes in patients, in these patients, if you give some drugs, or if you say if you have liver metastasis and you embolize that tumor, you can have a sudden release of all these hormones, and these patients have a rapid onset of because of this amines they go into hypotension and they have a very bad knees, they go into respiratory failure. So this carcinoid crisis. So how do you treat carcinoid crisis? Obviously, your octreotide has to be there. But apart from this, we give steroids and vasopressors. So that is one extra thing that is given in carcinoid crisis. All right. So we'll stop here. A few questions we still have. So we have to do that in 4 or 5 sessions because it is a lot of questions to discuss. So we'll stop here, and then next class we'll again have a set of questions to discuss. So idea is to just we should have a knowledge, a comprehensive knowledge of all the topics, not only the question answer. That is not helpful because next year they will not have the same questions. We'll have different questions, but the concept remains the same. So your idea should be you should have a good knowledge about the concept, and then you can answer any question if they ask. All right. Any questions? Okay. Thank you.